So the immune system is a really big deal for our body in terms of the way that it's able to protect us, keep us surviving, so that ultimately we end up reproducing. That's ultimately the biological goal for any organism. That being said, the immune system, just like any other system in our body, can end up working against us. Sometimes it's directly working against us in the sense that there's some sort of disorder or some sort of mutation, something isn't working the way it's meant to in our own body, and another times it's design in terms of the way it's supposed to work and what it does for your body on a regular basis ends up working against us from a medical standpoint. So we're going to take a look at some of the disorders and issues that end up coming from the way that your immune system works. So let's start with the allergies. So this is your immune system doing its job, but doing its job on the wrong type of antigens. So when your body is initially learning which antigens are harmful or pathogenic versus things that it's going to come in contact with just on any other cell, it needs to make that decision as to whether or not this is a problem, in which case I'm supposed to go through all of those lines of defense and actually fight it, make the B and T cells, make antibodies, get rid of the problem. But not everything that we come in contact with is really harmful. So every cell that's out there that exists, whether there are cells, plant cells, pathogens, all of these cells contain antigens. Those antigens are simply tags for identification, if you want to think of it that way. So your body is supposed to be able to recognize the pathogenic ones from the ones that aren't harmful, things like the pollen, dust mites, pet dander. And for whatever reason, in a decent number of us, our body ends up producing antibodies against allergens that we shouldn't. And those those antibodies end up on your mast cells, which are a connection to your inflammatory response. So when I look at something like hay fever, so you're allergic to pollen, the first time you get exposed to that allergen, rather than your cells learning tolerance to it, so not mounting an immune response, instead, you end up going through, and those B cells produce antibodies. Those antibodies end up attaching themselves to mast cells. Those mast cells are the ones that produce the histamine that gets released as part of your inflammatory response. So later exposure to that same pollen molecule causes a connection to the antibodies on that mast cell, which then triggers the mast cell to release a bunch of histamine, causing all of that inflammatory response symptoms that we think about. So you end up in anaphylaxis. So things like the runny nose, the watery, itchy eyes, hives, so the itchy, reddened skin. If it's inhaled, you may also end up with some of those asthmatic symptoms, the closing of your airway, making it hard to breathe. If it's something that's ingested, you may have some of those other reactions, including asthma, but you may also get cramping, vomiting, diarrhea. And for most of us who have allergies, this is where it stops. And so we're able to counteract it by taking antihistamines, so things like the Zyrtec, the Claritin, the Benadryl. We mitigate the symptoms. We stop the symptoms from happening, but as so long as we continue to get exposed to that allergen, that antigen on those things we're not supposed to react to, those antihistamines are only going to work for so long. All right. Once they wear out, get broken down in your system, you're back to taking more of them because the symptoms still occur so long as the antigen's still present. What really becomes a concern, however, is if you have a strong enough reaction that you end up in anaphylactic shock. So oftentimes this is because that allergen directly enters your bloodstream, so a lot of times anaphylactic shock is a big deal in things like bug bites, bee stings. That being said, we do see anaphylactic shock in some of our food allergies. Peanut allergies tend to be the biggest one that kids are aware of. And so rather than it just being a localized response, like the anaphylaxis, usually it's kind of just in your respiratory system, in your nasal cavity, that sort of thing. Instead, now we're taking those basophils, those mast cells that are part of that inflammatory response, and we're forcing an entire systemic body-wide response. And they're all releasing histamine all over your body. And your body just freaks out. So we get that construction of those bronchioles. Your airway closes up. you get this sudden vasodilation, and you're just leaking plasma and leaking cells out of your bloodstream at insane levels, which is then ultimately going to cause that low blood pressure, and if it's not treated quickly enough and effectively enough, can ultimately kill you. So what's the big treatment here? Well, usually it's epinephrine. So if you've ever heard of somebody who has an EpiPen, it's often because of some severe food allergy or because of some sort of bee sting allergy or something like that. That epinephrine is a huge anti-inflammatory steroid that we inject directly into your bloodstream as well, hopefully shutting down these cells so that you're not getting this systemic-wide reaction. Now, a lot of kids ask, well, where do the allergies come from? And the reality is that we really don't know for sure. But one hypothesis comes back to our hygiene. And not that we aren't hygienic enough, but in fact that we are overly hygienic. So we see this increase in allergies and asthma linked to decreases in childhood disease. And you're like, well, okay, why is that a bad thing that we're getting less childhood disease? It's not necessarily a bad thing. However, the fact that we're not exposing younger children to different pathogens, to different germs, their body isn't getting exposed to those allergens necessarily either, because we're just too clean. And so their body doesn't know what to ignore and what to mount an immune response to. So sometimes that initial tolerance to those allergens may be coming from just repeated exposure. Right? The more you get exposed to it, the less your body reacts to it. So something like having a pet. Well, you're constantly bombarded by the pet dander. So the allergens that are on there, your body learns to tolerate and ignore it and not mount an immune response against it. But because we are so concerned, so germophobic about bacteria and viruses, we're also cleaning all of these things to the point where the kids aren't getting exposed to the allergens either. So the pet dander, the pollen. And as a result, their body's not learning that tolerance at a very young age as their immune system is initially developing, and that might be where the allergies come from. Alright, something else that can cause us some issues. This isn't because your immune system's doing anything wrong, but in fact it's almost working too well. And so from a medical standpoint, it gets in our way. So when we take a look at blood transfusions, your blood cells are cells, so there are antigens connected to it. And we talk about your blood type, we're talking about, do you have A antigens, B antigens, Rh antigens, or what combination thereof do you have? Whatever your blood type is, your body will then produce the opposite antibodies, so antibodies against the antigens your cells don't have. And whenever we get that antibody-antigen connection, it's going to cause the red blood cells to stick together or agglutinate, and will ultimately cause them to burst or lyse. So what you don't want is to end up with a blood transfusion of a blood type that does not match yours. We talk about it as cross reactions. So one of the first things they're going to look for when you roll into the emergency room, if they can, if there's time, is what is your blood type? They want to know that. And it's a quick, easy test that they can do sort of on your bedside table, if you will. It doesn't take much. It just takes a little bit of blood and the right antibody serums. So when we look at blood types, right, type A has type A antigens, which means that your body makes the anti-B antibodies, so the one opposite it. Type B is the reverse, so B antigens, anti-A antibodies. If you're type AB, now your body has both A and B antigens. I can't have any antibodies in my body. If I do, they're going to react with my own cells, and that's problematic, so you don't have any. Type O is the opposite of that, where you have no antigens at all, but now your body makes both. So when we look at this, this really becomes important that we don't give you the wrong blood type, because if we do, you get this cross reaction. All right, opposite antibodies find their matching antigen. That shouldn't happen if you have the right blood type mixing. But if I get the cross reaction, everything sticks together, it clumps, and eventually bursts apart. That's not what we want. So when we were initially doing blood transfusions in sort of early medical interventions, we were thinking, oh, this is going to be a good thing. They're gushing blood, we're going to replace it. Problem was that we didn't understand this connection to the human's immune system. And so while sometimes it worked, we got lucky, we gave them the right blood type to function, a lot of times we got it wrong. And so we ended up killing the patient, maybe not because of the injury they had, but because of the blood transfusion we gave, right? Because ultimately this is going to end up systemic. So when we look at giving blood transfusions, we have to be careful that we're giving the right blood type to the right person. Now, there's some convenience in this. If you are a type O person, so your blood is type O, then you end up being the universal donor. You don't have any antigens to react with any antibodies that might be in somebody else's system. The reverse, though, you can only get from type O, because your body contains both antigens. If you're type AB, you're not the universal receiver. You can take from anybody because you don't have any antibodies at all, but you can only give to somebody who's type AB. So there's sort of a give and take depending on which end you're on with this. And then we also have to take into consideration the Rh factor. So you are considered Rh negative if you've never come in contact with an Rh antigen. If you have, whether it's because of this can pass from mom to baby, or you did have some sort of blood transfusion and you happen to get it that way, so it's very rare to be OH negative, but in terms of being a universal donor, that's actually the best option across the board, because now not only do I have to worry about the A and B antigens, I also don't have to worry about the Rh one. So when we talk about mom to baby, this can be a big deal. So this is usually one of the first things they do when you become pregnant, that they will test your blood and figure out what your blood type is, not just A, B, or O, but they also want to know if you're positive or negative. And if you're positive, it's no big deal. Or I should say it is not a big deal, but if baby's positive and mom is negative, then we can get this cross reaction, not the first time she has a baby, but the second time. And so they end up having to give her shots to keep her body from essentially rejecting and attacking the baby. Another medical intervention that we've figured out how to do, which is great, but our immune system gets in the way, are organ transplants. So remember, in part of that maturing process for your T cells, they end up in your thymus, and your thymus essentially teaches, for lack of a better word, those T cells your self-antigens, or that MHC, that masked histocompatibility complex, those proteins that allow those T cells to now distinguish your cells from the cells of some other foreign antigen. So those MHC molecules are genetically controlled. So unless you're an identical twin, everybody's MHC molecules are different. The question then becomes, how different? So if I go to stick a heart into a heart transplant patient, I have to be really careful of how different those MHC molecules are, because the more different they are, the more likely we are to get rejection of that organ. So when they're looking at organ transplants, they're looking at not only blood typing, but tissue typing. And we sort of look at the continuum of different options for a transplant. We can look at it like this. So if I start at the bottom, those xenografts are transplants or tissue grafts taken from another animal species. Those are the ones that your body is most likely to reject because they are coming from a completely different species, and so those MHC molecules are going to be dramatically different from what your body creates naturally. Next option up, slightly less risk of rejection, is an allograft. So most people who are on things like the organ transplant lists, this is what they're ultimately after. So you get a transplant between two human individuals, but they're not identical. All right. And as a result, those MHC molecules are going to vary, but now they're going to vary just a little bit less than that xenograft because we're at least talking from the same species. Ideally, that allograft is then coming from somebody in your own family because you're going to get even closer matches there. Next best option, if you have to go with a transplant from some other individual, is an isograft. That's a graft between identical twins. But how many of us are sitting around with identical twins? So that generally isn't the option. Okay, so allografts are next best, and first thing they're going to test for is your family members. Best case scenario, you're in a situation where you can actually take some sort of graft from your own body and move it somewhere else. So here's my story for the day. 6 months before I got married, my husband decided to go on a ski trip with the high school that he teaches at. They went up to Vermont, and he's a big snowboarder, but that particular trip he decided, I'm going to go rent skis and I'm going to try skiing. I skied as a kid, I was good at it, so why not, right? Well, I get a phone call on Valentine's to tell me, not Happy Valentine's Day, but I think I blew out my knee. Alright, and I'm like, wonderful. So he comes home, we find out, yes, in fact, he did tear his ACL, his MCL, and his lateral meniscus, and so he needed surgery to fix that if he ever really wanted to be super active again. You can actually walk around without all of those, alright, but you're not going to be anybody who's going to be super athletic. You're going to end up really having to favor that knee. So he comes home, it's the end of March by the time he gets his surgery, and they presented him with his options. So they could take part of his patellar tendon, which is the tendon that keeps your kneecap in place. They could take part of that patellar tendon from his opposite knee and use that as his new ACL, or they could take an ACL out of a cadaver, so a dead person. He ultimately decided that taking it from his patellar tendon was the better option. One, it was an autograft, so he didn't have to worry about rejection. Two, they couldn't guarantee where the cadaver was coming from, how old they were, what sort of condition they would be in beyond just matching tissue. So he wasn't really excited about potentially getting an ACL out of a 95-year-old man, so he decided to use his patellar tendon. So he ended up with an autograft. We didn't have to worry about the rejection. Alright. End of the story, right? I said it's 6 months before our wedding, so he literally finished his PT the week before we got married. So that was awesome. But he was at least up and walking and functional, which was good because we then obviously went on our honeymoon, and that was a lot of walking, and so he was able to function. So, yay! Great way to start off a marriage, but it worked. It was fine. Not that I didn't then fall off the porch and sprain my ankle severely 2 days before we got married, so we were quite the pair. So long as you didn't look under the garment, you didn't see all the things that were holding us all together, right? We had all sorts of ace bandages and all sorts of fun things. Anyway, so if you end up with an organ transplant that is not coming from yourself, right, then that means we're going to have to put you on some sort of immunosuppressant drug. Cyclosporin just happens to be a common one. The point here is that we keep you on that drug, hopefully not forever, but for long enough for your body to sort of tolerate that new MHC. So to decrease the risk that your body's going to reject that organ. We're doing that organ transplant for some sort of medical reason. We don't want your body to reject it, attack it, and destroy it. But sometimes, no matter how much medication we give you, your body does end up rejecting it, and that's where we end up in that problem of graft versus host disease. Transplant has to get removed, and now you're back on the transplant list. Alright. Here's another example of your immune system not working the way it should. And those are autoimmune diseases. This is some sort of disorder. It's a class of disorders, class of diseases, where your immune system is actually attacking your body's own cells or own molecules. Somehow your body has lost the ability to recognize your own cells and differentiate them from things that shouldn't be there. So it just thinks everything's a problem. We don't really know why these diseases show up. Some of them people are born with, some of them show up somewhere along your lifetime. They seem to just kind of develop. We know that there's probably some genetic factor because we see a lot of them run in families. But ones that don't, or why they show up when they do, we think maybe has some connection to toxins you may come across in your environment, or maybe even connections to certain viral infections. And how do you really avoid that? Well, the only option really is vaccination, and we're not quite there for everything yet. The other thing we've statistically been able to tease out is that for whatever reason, these autoimmune diseases also tend to affect women more than men. So we're talking things like lupus, rheumatoid arthritis, multiple sclerosis, even type 1 diabetes. These are all examples of autoimmune diseases. If anybody has eczema, that's another one. An interesting side note, one of these days I'll have to find this article and send it to you guys. The eczema they think might actually be connected to a bacteria that's supposed to be in your digestive tract, somehow got loose, somehow got somewhere else in your body. And so your body's attacking it, but in that particular region it sort of lost its ability to recognize, in the process of fighting the bacteria, it's lost the ability to recognize your own cells. And so it just starts continuing to attack everything in that area. So there's some looking into, can we just treat eczema with some antibiotics if we can get rid of that bacteria? So it'll be interesting to see, one, if that study continues to hold up as they do some more research, and two, if it does in fact have a connection to this bacteria, are we able to maybe treat it some way, as opposed to just the steroids that we're using right now, which really all we're doing is suppressing the immune response. We're not taking away the disorder, it's not disappearing, we're just treating it, we're just minimizing the symptoms. And really that's how treatments for any autoimmune disease work. There really is no cure for it. All we're doing is mitigating the symptoms. So suppressing the immune response, which has its own side effects, right? Because now if I'm suppressing your immune response for that, I'm repressing your immune response for every other pathogen you come across. Or sometimes we can replace the molecules that your body's destroying. Think of the diabetes. We can give people insulin because they can't make it themselves. So it'll be interesting to see. This is a big area of medical research right now because we really don't understand why it works or how it comes about, and yet we're seeing an increase in the number of people who are being diagnosed with it. Immunodeficiencies are another thing we can talk about. So this is a situation where something has happened that causes your immune system to just be completely ineffective, or at least decrease its effectiveness, so that we're no longer able to respond to those antigens that shouldn't be there. SCID babies are one example. So the baby is born without the ability to produce B or T cells. They're completely missing the stem cells that create those. And so as a result, they have no third line of defense, which is going to be problematic because remember we said a couple of days ago that when we look at your second line of defense, it's great, it's a start, but a lot of pathogens, because it's been around so much longer than your third line, those pathogens have figured out and evolved ways around your second line of defense. So that third line of defense is sort of our co-evolutionary response to that. Well, if I don't have that, I'm still going to get exposed to those pathogens because they're going to infect me. They're human specific. And now I have no way to fight it, nor do I have any way to remember it. So a lot of SCID babies tend to not last much more than a year because they're going to constantly be sick. And eventually something's going to come around that ends up being fatal to them. AIDS is another example. So we decrease your ability to protect yourself against disease. And this is often a big one for AP. So let's sort of take a look at how HIV and AIDS works. So remember, if we go back to viruses, HIV is a retrovirus. So it's an RNA virus that contains a bunch of proteins. It's enveloped, so when it fuses with our cell membrane, it releases the RNA into the cell, and off go a bunch of enzymes to work to get that RNA back into DNA form. That DNA then gets integrated with the help of other enzymes into the host's DNA so that it can take over the host's transcription and translation processes to then make more viruses from there, but off goes that virus to go infect a new cell. So HIV becomes a really big problem because the cells that it's infecting in our body are your helper T cells. And if you remember us talking about the importance of your helper T cells, they're the ones who get that initial secondary signal from a macrophage, from your second line of defense, and then go and tell the rest of your B and T cells, yes, this is in fact a problem, we need to do something about it, So it turns on your B cells to go become plasma cells and make antibodies. It goes and turns on your cytotoxic T cells to destroy cells that are already infected or any other pathogenic cell that's in your body. So if I shut down those T cells, both your humoral immunity, so the B cell side, and the cell-mediated immunity, your cytotoxic T cell side, is completely turned off. It destroys it, it decimates it. And so most people who have HIV or ultimately end up getting to the AIDS prognosis don't die from the virus itself. Instead, they're dying from some sort of secondary infection because they've got no way to protect themselves against something as simple as the cold or the flu or strep throat. And also remember, those cytotoxic T cells are also there to help protect you against cancer. So maybe it's not a secondary infection that gets them, but it's cancer instead, because their body's got no way to stop those tumors from forming in the first place. So when we look at the HIV infection, we split it out into 3 different categories, or 3 different phases. Your first phase is the acute phase, and this is really the big problem, because when I look at you, you're asymptomatic, you look healthy, you feel healthy, you don't necessarily recognize that anything is wrong. And so as a result, you're not changing your behavior patterns, and so you are highly infectious, passing on that virus. And in fact, initially in that very early part, where you don't feel anything, look at the height of your viral load. Now it drops off a little bit, but initially within that first year, you're not symptomatic. You're carrying around this huge viral load, so you're passing that on to people. And even in that very early part of this phase, you may not even show up on a blood test that you're infected. So it's quite the sneaky little disease in the way that it works. It gets passed on from one person to the next. When we finally start being able to diagnose this, one of the first things we do is look at your T cell count. And for a normal functional living adult without HIV, you're usually looking somewhere on the order of about 800 cells per cubic millimeter of blood. We get to this first phase of somebody with HIV, and we're going to see somewhere on the order of about 500. So it's not dramatically different from your normal T cell count. Once again, that's why you feel fine, and it's also why it may not show up in a blood test yet. We get to the chronic stage, and now you're down to anywhere from 200 to 499 cells per millimeter of blood. All right, so considerably lower. And the lower those T cell counts, the more these symptoms below seem to be problematic. So you got persistent lymph nodes, severe fatigue, fever. Why? Because you're fighting other infections and not doing a very good job of it. You may get some nervous system impairment. This may be where we get some cancerous tumors showing up. You're losing weight. You're depressed. Now the depression question is it because of your symptoms and your diagnosis, or is it really because of some nervous system impairment? Maybe both. But the hope is that we diagnose you back in that acute phase and try to keep you there. All right, that you're never really into this chronic phase. If it persists long enough and it's not treated, we can ultimately end up in this final phase, which is where we talk about you having true full-blown AIDS. All right, and at this point, your T cell count is below 200 cells per cubic millimeter of blood. Your lymph nodes are completely falling apart. Patient's really weak, really frail, really thin, and this is really where those opportunistic infections come in and destroy you. Or the cancer comes in and just destroys you. So generally speaking, if somebody gets to the point where they are actually diagnosed with AIDS, best case scenario, they're given 2 to 4 years. So the goal is, although there's no cure for AIDS, we do have ways to keep your HIV viral load low. So the lower we can keep that viral load, the better, because then it also means that your T cell count remains higher. So we try to keep patients back in that chronic phase, and preferably back here, where you've got a higher T cell count than you do viral load. So how do we do that? Well, it's going to require drug therapies, as well as continuous monitoring. So historically, we talked about this HAART treatment. So it's a cocktail of different medications that are interfering with the HIV infection by targeting its 3 biggest enzymes. So the reverse transcriptase, if I target that, then that means when that virus connects to a cell, spits in its RNA, it can't take the RNA and convert it back to DNA. If it can't convert it back to DNA, the cell doesn't know what to do with it, and it stops the virus there. It also targets the integrase. The purpose of that integrase is to take that DNA and integrate it into the host's DNA. Well, if I don't have the integrase, I can't do the integration. And so once again, the cell doesn't know what to do with that extra DNA. We also then end up targeting the protease. Those proteases are part of the production of the virus's envelope. Again, if I shut down the production of those proteins, then there's no functional virus to get out of the cell and go attacking other cells. So ultimately, the goal is to keep the viral load down. The lower the viral load, the higher your T cell count, and the healthier you ultimately are. So how do you stay healthy in general? All right, from any pathogen that you come across? Well, first off, washing your hands. That's why we do the hand washing demo, so that you really get a sense of what it means to thoroughly wash your hands, because most of us don't spend the time to really do that, and yet it's probably the most effective way to keep pathogens from spreading. Eating a balanced diet is always a good idea, right? If your body is getting the nutrients that it needs, it's not getting depleted, it's not having to work harder to make what it needs. Same thing with the sleep. All right. On average, they say most people need about 8 hours. Okay. The avoiding and managing stress, well, let's get real. It's probably impossible to completely avoid the stress, but can you find ways to manage the level that you have and to sort of calm yourself down when you do get in those stressful situations? And for some people, exercise is that stress management. So not only is it good for your body just to sort of keep your metabolism working and keep weight off, keep your glucose levels in check, keep all your body systems working the way they should, but it can also help to manage that stress as well.